And then we're going to cover chronic inflammation. And I'm going to give another biomaterial example. But then there's a series of slides in the back of the slide deck that we won't get to. They're just more material for you in case you're curious. So again, and I'll explain this when we get to the end of class, but if we don't cover it in lecture, then I'm not going to hold you responsible for it on the exam. But sometimes students want to know more, just if they're curious about things. So I included a whole group of slides at the end of your slide deck that are about biomaterials and inflammation. So we're just going to cover one other example. So I don't want you to think how in the heck are we going to get through all this? That's always been the plan. And I'll remind you of it when we get there, but that back stuff won't be testable. We'll just have a component of it that I'll talk about, and then we'll finish our time together. So the different types of inflammation, very similar to the different types of necrosis. We can characterize them in sort of 4 main categories. So we've got serous, fibrinous, superlative, or an ulcer. So with serous, we have a watery protein poor fluid. And we see this most oftentimes evidence is a blister. Okay, so evidence of a blister is that serous fluid as a result of that serous inflammation. We might actually see fluid in a serous cavity known as an effusion, for example, pleural effusion. So in patients that have compromised lung performance, or maybe they have a tumor in the lung, they're going to be producing additional fluid as a result of that inflammatory response. And that's a serous type of inflammation. Serous inflammation, not serious. Serous inflammation. The second type is known as fibrinous. So fibrinous is when you've got a more extensive type of injury, and you get a fibrinogen that develops, and a meshwork or a coagulum that's eosinophils in nature. We see this a lot of times in inflammation of body cavities. Superlative, another word, the third one, another word for it's purulent. This is an exudate. So you get pus from this type of inflammation. So a purulent exudate usually comes from the neutrophils and the necrotic cells and edemic fluid that are sort of carnage as a result of the battle. Okay? So the neutrophils and the exudate, the exudate is made up of, or the white pus is made up of neutrophils and necrotic cells and edemic fluid. And the microbe itself will stimulate a lot of pus. Oftentimes, if it's a pyogenic situation where you've got the microbe in a pyogenic infection causing the pus, giving rise to this purulent discharge. A abscess is a local accumulation of that pus that's contained within a tissue. And it doesn't actually get discharged or get released. And so it forms a nodule of pus known as an abscess. And then the last category, and then I'm going to go through the histology. The last category is an ulceration. This is an erosion of an organ or a tissue, usually due to the shedding of necrotic cells. So as they die, they shed. So the ulcer example is the lower left. This is a duodenal ulcer on the lower left right here in the small intestine. You can see this is the intestinal epithelium. This is a Peyer's patch here and here and here. This should actually connect, and this is the ulceration that's taking place, usually due to malfunctioned pyloric sphincter, where it's dumping acid too frequently into the duodenum, or the small intestine. The lower right, so we're moving counterclockwise, this lower right is purulent inflammation of the lung. And you've got neutrophils that are collecting in this area. Those are those purple dots. And the red streaks that are here are the vasodilated vasculature that's bringing in additional fluid. And then the upper right is a fibrinous type of pericarditis, or a fibrinous inflammation over the heart. And we've got deposits of fibrin that you can see as they reflect back. So here's the pickups, here and here, or forceps. And this fibrin deposit is this whitey, sort of white, off-white color. Not the glistening part, but like right here. See how it's kind of dull? This is shiny and this is dull. The dull part, or the sheen that's more matte in appearance, is the fibrin deposits. It should be more glistening, like what's shown down here. Like all of this glistening, like if you're using flash photography, it looks wet. This dull matte is the fibrin on the top. And this is the heart below it, or a component of the heart. Okay, if we consider inflammation, we talked about how it's acute in nature, it's a defense mechanism, it's supposed to be there. What happens if it goes chronic? Well, chronic is going to be down this category. So if we follow the different outcomes, we've got acute inflammation, and we can see, again, we're back to our blood vessel picture. So we've got injury that could be either like an infarction, bacterial infections, toxins, or trauma that causes this vascular response to recruit all of these macrophages on the outside. Well, if it resolves and goes back to the normal vasculature profile, then you see it returning back into this sort of vasoconstricted format. But it can also progress in this direction. Oh, so let's go this way. It can progress in this direction where we remodel the tissue and we get additional fibrotic scar that takes place. So as a result of that healing response, we brought in new fibroblasts. They make new collagen, new extracellular matrix, and as they lay down that material, it's not organized in its normal architecture like it was before, and that's where you get scarring. And scarring is another word for fibrosis. And we say in this category, we've got a loss of the function of that tissue. And so if you think about wounds that have healed where there's tremendous fibrosis or scarring, let's take, for example, a cut on your skin that's an aggressive scar. The reason we would say it has no more function, or it lost the original function, is it's fibrotic, disorganized scar tissue. It probably doesn't have hair cells growing back. It doesn't have the sweat glands that it normally had. It's just a patch. Versus up here, with resolution, if you return to normal function, then you restore all of those constituent parts of that organ and you don't have scar. Well, we see the same delineation occur in cardiac tissue, in brain tissue after a stroke, in liver tissue, in cirrhotic patients with cirrhosis versus patients that just have maybe alcoholic hepatitis or steatosis. We see it happen in kidney infarcts, patients that have infarcts of the kidney. So if you get scarring, you've lost function. So if you had a family member that had a heart attack or a myocardial infarction or an MI, and they say, you know what, Grandpa survived, it's good news. We just don't know what the outcome's going to be yet because we don't know how much scarring. The doctor said we're not sure how aggressive the scarring is on the heart. This is what they're talking about. They're trying to evaluate how much fibrosis versus regular healing took place. Okay? So these are the two main outcomes, this way and this way. This third outcome that we're going to talk about a little bit later is chronic inflammation, where it never resolves. The blood vessels never vasoconstrict, they never go back to their native shape. You continue to recruit macrophages into the area, They make scar as they go along to try to patch it up, but you never get rid of those macrophages. This is going to be our chronic inflammation, and we see this in things like viral infections, chronic infections, persistent injuries, or autoimmune diseases. So these diseases or these injuries that stick around for a long period of time lead to a state of chronic inflammation versus acute. They never allow the inflammation to subside. Okay? Sort of a intermediate step here is one where you get a lot of pus formation, or that abscess that's that pocket of pus that never resolves. So these are all our possible outcomes with an inflammatory response. And now what we need to do is talk about some of the chemical mediators that make this possible. Okay, so again, now we're going into mechanism. So some of you got excited and others got really nervous. Okay? In the mechanistic pathways that we're going to explore, I'm going to try to dive it down very simplistic. As simple as I possibly can. And we're going to focus on things that I say in the lecture that we know are going to be testable mechanisms on the exam. Okay? So, these chemical mediators that stimulate this inflammatory response to take place can come from either two main sources. They can either come from the cells themselves, which is called cell-derived, which is written right here on the side, or they can be found in the plasma, which is called plasma protein derived. If they're cell-derived, they're either already made, sitting on the shelf, so to speak, in these secretory granules, or you actually have to manufacture them, newly synthesized. If they're from the plasma, then they ultimately came from the liver, because the liver is responsible for making all of the main proteins that are found in the blood plasma. Okay? So we either got cell-derived, they're already made, or you make them fresh, or we got from the liver. You with me so far? If we look at our secretory granules, the two main ones are histamine and serotonin. And histamine is a vasodilator. Serotonin can have either vasodilation or vasoconstriction properties, but it most commonly acts as a vasoconstrictor. Why? Well, it helps in blood stasis. Okay, so I'll come back to that here in a second. Next up, on the newly synthesized, where you manufacture them, you make what we call prostaglandins, leukotrienes. Okay? You also make things like ROSs, which we talked about. You make nitric oxide, which we talked about. And you make a number of other cytokines and neuropeptides. For the purposes of this slide and the next slide, we're going to focus on the prostaglandins and the leukotrienes, because we've already really paid attention to the ROSs and the nitric oxide before the break. Okay, so I'm going to talk about prostaglandins and leukotrienes in just a second. Now from the liver, we really only got two main categories that are made from the liver. Complement, which I mentioned earlier, and then we've got factor 12, known as Hageman factor. Complement assists a lot with inflammation and also with lysing the cell, and I'll talk about that here in about 2 slides. And then in about 3 slides, we're going to talk about the role of factor 12, or Hageman factor, and its role as it relates to the kinin system and the coagulation system. Okay? So first up, as I promised, is leukotrienes and prostaglandins. Again, this looks like a super busy slide, kind of like the last one, but we're going to dissect it down very systematically. So, eicosanoids. Eicosanoids are a family of manufactured carbon compounds. So they're 20 carbon compounds. They're essentially fatty acids. And we've got 4 main categories that we're going to look at. Prostaglandins, prostacyclines, thromboxanes, and leukotrienes. So all four of those are types of icosanoids that are manufactured. They're manufactured by the phospholipid bilayer. You take the phospholipid bilayer, use a phospholipase, and you make what's known as arachidonic acid. And arachidonic acid is this intermediate that goes down this pathway to the left or this pathway to the right. Okay? So you take the cell membrane, pretty clever, you digest it with a lipase, and you get arachidonic acid as your starting ingredient. And from that starting ingredient, you can either make what we call the family of prostacyclines and thromboxanes and prostaglandins, or you can make the family of leukotrienes. Okay? So if we go to the left, arachidonic acid, using this enzyme known as cyclooxygenase, you make a family of prostaglandins. You follow this down to this pink box. Prostaglandins cause vasodilation and they increase vascular permeability. Why would that be valuable for inflammation? Anyone? Don't all like say it at the same time, because then it's hard to figure out where it came from.
It allows nutrients to get to the source of.
Okay, perfect. It allows for nutrition to flow out of the blood vessel in the form of plasma proteins and plasma fluid. Okay? We just covered that, right? Now, you can also, with cyclooxygenase, you can actually manufacture prostaglandins that become prostacyclin, which causes vasodilation, or thromboxanes, which cause vasoconstriction, and they promote platelet aggregation. Now, let me ask this question. Vasodilation, this answer is the same as this box. Why would this box, in an inflammatory response, why would you also be causing vasoconstriction at the same time that you're causing vasodilation?
Start the platelet plug.
To start the platelet plug. So you can actually stop this process from happening. You don't want it to, you don't want yourself to like lose all your fluid. It's a controlled vasodilation, and you actually slightly coagulate it at the same time. And that's a benefit for another reason that I'm going to talk about here in a second. Okay? Now that's this side, the left side. The right side, we go arachidonic acid using lipooxygenase, and we form a family of leukotrienes. The leukotrienes are noted by this box. They cause vasoconstriction as well. Okay, so the vasoconstriction of the leukotrienes, as well as the vasoconstriction of the thromboxanes, help with managing the level of vasodilation so you don't just blow your vessel out completely. And if you notice here, it also, at the same time, causes an increase in vascular permeability, right? So it actually makes it leaky, but yet it constricts. So the boxes to remember on this slide are arachidonic acid. I'm going to put a circle here. This box, this box, this box, and this box. And generally understand that icosanoids, there are 4, and they're intimately involved in this inflammatory process. Now, if you have a chronic inflammation that's taking place clinically, and you want to slow things down pharmaceutically, you can, some of you are like, I really could care less about this slide. Actually, you will care about this slide, okay? If you're going to be a nurse or a physician, you're going to care about this. If you've ever taken aspirin or like sprained an ankle or taken a steroid for an inflammatory infection, you're going to care here in just a second. And this is why we understand these pathways. This is why we talk about these pathways. So if you look, there's 2 X's on here. If you take a corticosteroid, you block the formation of arachidonic acid. And look at what happens downstream. You get no icosanoid formation whatsoever. So you significantly diminish the inflammatory response by taking a corticosteroid. Make sense? You don't make arachidonic acid. Now, if you use a COX-1 or a COX-2 inhibitor or aspirin, you block the formation of arachidonic acid into the prostaglandin intermediate. So you don't get any of these isocinoids down here on the left. But if you use COX-1, COX-2 inhibitors or aspirin, you still make leukotrienes. So aspirin is over the counter. So over-the-counter anti-inflammatory in aspirin is actually pretty good. If you want to go more powerful than that, prescription dose corticosteroid blocks the whole thing. So you may only want to block a little bit in that patient to start, and then decide if you want to go, with both guns on a glucocorticosteroid. Make sense? So that's where these drugs fit in. Okay. If we look at the plasma mediators, sort of third on our list are these mediators known as complement. Now, complement is an interesting molecule. We're not going to spend a lot of time on it, but what I want you to know about it is the following. The complement factors stimulate or induce, this is down here, an increase in vascular permeability, leukocyte activation, adhesion, and also phagocytosis. They help. That's what we call complement. They're manufactured by the liver, and they assist in a variety of these processes, including assisting in the inflammatory process. They are part of our innate immune system, complement. So there are three activation pathways. I don't really care that you can discriminate amongst them. Just understand that these three pathways ultimately converge. And here is our outcome. Here's inflammation utilizing the C5a and C3a complements. Phagocytosis utilizing C3b. And then the formation of a MAC complex. This is quite interesting. In the formation of a MAC complex, you've got the insertion of your C3b into the membrane of the microbe in a fashion that creates a hole. So it literally assembles, Lego style, a portal that leaks the contents of the bacteria out, and it just sort of deflates the whole thing. It causes cellular lysis. So, three main outcomes, right? Inflammation, phagocytosis, as well as the formation of this MAC complex. There's a question in the back.
What would be the purpose of blocking the pathway from the previous line? Like, why would you want to inhibit that being produced?
So the question is, why would you want to block inflammation? So let's say, for example, you have a patient that has they're having an asthma attack, and it's chronic, and they're not responding to bronchodilators. And so you put them on a local corticosteroid to block inflammation in the airways of the lung. And usually that's in the format of an inhalant. So you breathe it in, and it locally acts. They don't go pump iron and become Arnold Schwarzenegger. It's a local acting corticosteroid that blocks inflammation in actually this whole inflammatory pathway in that particular patient. So that's one example. There's a lot of autoimmune disorders that have rampant chronic inflammation. And so we put the patients on corticosteroids to bring the inflammation level down in a lot of these. So like in MS, a lot of times in multiple sclerosis, we'll put patients on corticosteroids to try to calm down that inflammatory response. So they're used in a lot of different scenarios clinically. Does that make sense?
Would that make them immunocompromised in a way if they're on these corticosteroids because they won't be able to respond to that?
So the question is, will that make the patient immunocompromised if you're on this corticosteroid? Sort of is the answer. So their inflammation response will be diminished. If it's a local acting, like in the case of an inhalant, then it's not as big of a deal as if you take it systemically as a pill. But remember, there's a whole other side of the immune system that involves B and T lymphocytes that we haven't talked about yet, and that's fully still functioning. Okay. The last component of this section, and then I'm going to summarize it, is the kinin system. So, and coagulation. So factor 12, our Hagman factor, is shown up here at the top. And if you remember back to 202, this should be somewhat familiar, because in 202 you talked about both of these pathways, or you should have talked about both of these pathways. If you go from factor 12 to factor 12A in its activated format, you can either go to the left or you can go to the right. If you go to the right, this is the clotting cascade where you start this, 12A activates 11 to 11A, which activates 10 to 10A, so on and so forth. You get down to 2 to 2A. 2A is thrombin that's formed from prothrombin. Thrombin has activity to take fibrinogen to fibrin, and the fibrin is what builds up that clot, right? This is coagulation of the blood. Now, to the left side, we go through this kinin cascade, and ultimately you get plasmin. Plasmin stimulates the complement cascade to make C3 go to C3A. C3A was that complement protein that helps to facilitate inflammation. So, when you're thinking about inflammation, and you think about factor 12, or Hagman factor, the purpose of this pathway, the kinin cascade, is obvious because complement C3A supports the inflammatory response. This one is a little bit less obvious, and this one is important for you to understand. The reason that you would want to stimulate a fibrin plug, as we were mentioning earlier, is you ultimately are going to want to plug those holes that you've created, those gaps. In addition to that, you want a controlled coagulation that's ever so slight to kind of slow down blood flow. And the reason that you want to slow down blood flow when you're trying to recruit monocytes out to become macrophages is why. Why do you think you need to slow down the blood flow a little bit? Think about the video or the school bus, getting off the bus example. You want that blood to be a little bit slower to allow for those monocytes to find the selectin. If they find the selectin and they break the bond, then they start their rolling process. And that rolling process is what triggers integrins to be expressed. Right? So the stages that we have are, we have rolling, right? When integrins are expressed and bind, that's considered tethering. So we have rolling, tethering, and then we have diapedesis where it squeezes through, and at the end we have chemotaxis where it moves to the bacteria that's causing the problem. You with me? So the rolling part is preceded by a step known as margination, where those monocytes move from the middle of the blood flow to the edge where they can find and interact with that selectin. And the reason that they marginate is because you slow down blood flow. Make sense? Okay. So, a summary slide. What do these mediators do? We've got vasoactive amines, icosanoids, complement, kinin, and coagulation pathways. What do they do? Well, this is a summary of what we just talked about mechanistically. To kind of help you study. So, histamine, released by mast cells, basophils, and platelets, increases vascular permeability and allows the white blood cell to move out of the bloodstream. Serotonin comes from platelets. It regulates hemostasis and blood clotting. It has dual activity. Causes vasoconstriction and causes vasodilation. However, you need both to take place so that you manage the amount of dilation that takes place. Icosanoids. We have four families: the prostaglandins, prostacyclines, thromboxanes, and leukotrienes. And they have a variety of different vasoactive effects. They either cause vasoconstriction or vasodilation. similarly to serotonin. They stimulate chemotaxis as well in some cases bronchospasm. The bronchospasm example is the leukotriene over here. I kind of skipped over that terminology, bronchospasm. Complement. 3 activities: increasing capital permeability, leukocyte activation, as well as phagocytosis. And then lastly, the kinin and coagulation cascades stimulate the ability for hemostasis to take place and for you to be able to recruit cells. Questions? So that wraps up acute inflammation, and we're going to pick up chronic next week. And I'm going to give you a clue. The biggest difference is just time. We're going to see a couple of other mediators, like foreign body giant cells that show up, and we'll talk about them next week, okay? Don't forget your post-quiz due by Friday at 11:59 p.m.